Good morning. Thank you, brave souls, for venturing out here. I don't think you'll be sorry. I'm Connie Weisner. I'm on the faculty here, and I'm very happy to introduce Stacy Sterling to you. She's a research scientist at the Division of Research, Kaiser Permanente, Northern California. She is a graduate of Wesleyan College. Then she got both a master's in social work, social welfare, and public health at UC Berkeley, and then a doctorate in public health at the Gillings School of Public Health at the University of North Carolina. She has been at the Division of Research for quite some time and has done a series of very interesting pragmatic trials and observational studies, both using trials and using the EHR, electronic health record. She has two main areas of research. One is adolescent research, which she's not talking about today, and the other one is implementation or dissemination research, and these often combine. And I want to just mention a little bit of her adolescent research in case any of you are interested in reaching out to her for working together or whatever. She is leading studies that she is both from the National Institute on Alcohol Abuse and Alcoholism, the Robert Wood Johnson Foundation, and now also the Hilton Foundation. She did an adolescent study in pediatrics on screening, brief intervention, and referral to treatment for adolescents, where she randomized physicians, pediatricians, including some residents from UCSF who were doing their work there, to doing screening, brief intervention, and referral to treatment for kids with both substance use and mental health symptoms. Then she followed that with and that was published in JAMA Pediatrics. Then she followed that with a study from the Hilton Foundation where she is doing 4 sessions in pediatrics for kids who have symptoms with the kids and their parents, because kids do not often, and their parents don't often want them to go to specialty care. And that's a very exciting study that's in process right now. And she also has a grant from the Conrad Hilton Foundation to do a predictive modeling study using the EHR, and she's doing that with 5 different health systems. She has a cohort of kids who are 18 who were born in these health systems, and she is looking at predictors of developing substance use and I think mental health conditions over their lifetime in terms of who to target for prevention and early intervention. So she's doing some very interesting work with adolescents. What she's going to talk about today is her dissemination work. And this is a big study from NIAAA that randomized, as she'll tell you, many clinics in Kaiser Permanente to different ways of doing screening, brief intervention, referral to treatment, and then how she made the rollout happen. And I know she won't say this, but I really have to say that I don't think this would have happened without Stacy. She is really pretty magical in working with complicated systems, stakeholders, whether it's leadership, very busy primary care physicians, asking them to do more. I think the biggest compliment on this study was that a leadership in Kaiser at a big national meeting they said, how did you get your physicians to do this? And she stood up and she said, because they make our work easier. So that is our goal, as so many things are being pushed upstream into primary care, is to really embed mental health and substance use services in primary care so that people get reached earlier and effectively. I just want to also give a shout out here to Derek Satry, who you probably all know, who is an adjunct over there at Kaiser Permanente also, and has had a big role in many of these studies, works closely with Stacy and the other team members over there. He's also someone you can always contact if you're interested in doing work over there. So without further ado, thank you, Stacy.
Thank you, Connie, for that really great introduction, and thanks all you Hardy folks for coming. I want to acknowledge my co-authors, not only our research team, but also many of these folks up here are our clinical collaborators, and as you will see, I hope, this was a real collaboration between research and clinicians in our health system. So before I talk about this project, I want to give you a little sense of a conceptual model that we use to really frame many of our studies, including this one. Talk a little bit about SBIRT, Screening, Brief Intervention, and Referral to Treatment, and I think most of you are probably familiar with SBIRT. Then talk about how we took findings from a cluster randomized implementation trial that we did and really implemented them in our health system as part of the regular clinical workflow, and how we have developed, based on our experience with that, developed a framework for SBIRT implementation, which we are now using to roll out SBIRT across all of the Kaiser regions, and we're also, working with the CDC and the National Association of Chronic Disease Directors, and I think this is informing their SBIRT implementation work. And I'll show you a few examples of how the factors in this framework are operationalized, and then talk about things that are going on now. Most of you, I'm sure, are familiar with Kaiser, but in case you're not, we are a very large, integrated, nonprofit healthcare delivery system in Northern California. We cover a lot of the region. We're very diverse geographically, going from the Sierra foothills to the Bay Area to Santa Cruz to the Central Valley. We have about 4 million members, almost half of the commercial market share in the region, and very diverse also racially and ethnically, linguistically. We have a mature, robust EHR. We were early adopters of EHR technology, and so, it's just part of our system and a key factor you'll see in our SBIRT implementation. And we're an integrated system, so we have carved in psychiatry and addiction medicine services for the vast majority of our members. So this is a conceptual model that we published 10 years ago, and it really has informed much of our research, certainly this project. And we really see, it's an iterative model. We really see our research questions emerging not just from the literature, but very much from the stakeholders in our healthcare system. So we get important ideas for informing research questions from our providers, from policymakers, from the patients that we talk to in our current studies. Many of our studies have come directly from, providers saying, why aren't you studying teens? You're studying adults all the time. And that really, started our entire program of adolescent research. So we see them informing our research questions. We do efficacy and effectiveness studies, and then implementation studies, all the way along, stakeholder input and feedback, informing how we interpret our studies, and then feed that back into this loop. So SBIRT, for those of you who might not be familiar with it, SBIRT is an evidence-based approach to unhealthy alcohol use, or in this case, alcohol use. It's a public health approach. It includes systematic screening using standardized evidence-based screening tools. In our case, we've used the NIAAA screening tools. However, the audit or the CRAFT for adolescents are often used. Also, a standardized protocol for conversations about substance use. These are informed by motivational interviewing and motivational enhancement techniques. They're very client-centered or patient-centered. And then a standardized protocol for referring those people with more severe problems, to specialty treatment if necessary. And it's really focused on the top of the pyramid here, so those people who are drinking at an unhealthy level. And then those people who are severe enough where it's likely that they have an alcohol use disorder. In primary care, we're primarily focused on the unhealthy drinkers, so the orange there. And most of you are also aware of the limits, but in case you're not, the safe drinking guidelines as laid out by NIAAA are for men between 18 and 65, no more than 4 drinks per day and no more than 14 drinks per week, so an average of no more than 2 drinks per day. And for women and men over 65, it's no more than 3 drinks in any given day and no more than 7 drinks per week, so an average of about a drink a day. And anything above that is considered unhealthy drinking. So why address heavy drinking? Because it exacerbates a number of common chronic health conditions, such as hypertension, diabetes, and so forth, depression, anxiety, and panic disorders. It increases risk for injuries and accidents, STIs, and a number of different cancers. It's a direct cause of alcohol use disorders, of course, and then another other health problems like cirrhosis and pancreatitis. And it also reduces medication adherence and adherence to self-care regimens, such as diabetes medication and antihypertensives. And that's of real concern, obviously, in primary care. Alcohol screening has gotten a lot of press, even in the popular press recently, and it's become an important focus of the CDC. So, you see Tom Frieden's statement here, and it was a big emphasis in the recent Surgeon General's report, if any of you have had a chance to take a look at that, which was sort of a groundbreaking report on addiction. There's also a long history of efficacy evidence on screening and brief intervention for alcohol. So there are studies going back 40 years now demonstrating its efficacy and cost-effectiveness studies showing that for every dollar spent on screening and intervention for alcohol, healthcare costs are reduced by $4. So it's been shown to be cost-effective. It's recommended by the U.S. Preventive Services Task Force that all adults age 18 and older be screened regularly for alcohol misuse and provided with brief intervention. And the National Commission on Prevention Priorities, which looks at the preventive services recommendations of the U.S. Preventive Services Task Force and ranks them based on clinically preventable burden and cost effectiveness, ranks alcohol misuse screening and brief intervention number 4. And you can see that it is ranked above things that we very commonly do, like hypertension screening and cholesterol screening. So we, prior to our SBIRT work, we had been doing some screening studies on our research team in a number of different settings. So we did some screening studies in mobile health vans across Alameda County. We also conducted screening some screening studies in Kaiser primary care to get a sense of the prevalence of alcohol, unhealthy drinking, and health conditions in unhealthy drinkers in Kaiser Permanente. We've also done screening studies in South African primary care clinics. And this was all building up to our what became our SBIRT work. So back in 2010, Jennifer Mertens, who was at that time with our research team, was the PI on a study that we conducted across our region. It was a cluster randomized trial of implementation because SBIRT, in spite of all of the efficacy evidence that I talked about, SBIRT really had not been implemented widely in many systems, really outside of the VA. So And, you know, there are a lot of challenges, a lot of barriers to implementation. So this study really looked at what was the best way to deliver SBIRT. And in that study, we randomized primary care clinics. And in one arm, we taught all of the physicians how to deliver SBIRT. So they did this. We taught them how to use evidence-based screening tools. We taught them how to deliver a brief intervention, and we taught them how to refer people to treatment. In another arm, we had medical assistants conducting the screening. And we had non-physician providers, and that could have been a nurse, or it could have been a clinical health educator, it could have been a behavioral medicine specialist, but someone that the clinic chose, and they delivered the brief interventions and made the referral to treatment if someone was determined to need that. And then there was a usual care arm. We took our findings from that study and have now sort of looked at what worked and what didn't work, and have chosen a sort of a hybrid model to roll out across the region. And I'll show you how that has worked. So we went from, and the ADVISE study had over 500,000 patients, over 500 primary care providers that we trained. So it was a huge undertaking. So I'm sorry, I anticipated myself. I went through this. So this was the primary care provider arm and the non-physician provider arm with the medical assistant screening. So what we found was that in the primary care provider arm, those patients who were identified as being at risk, a pretty good percentage of those actually were given a brief intervention or a referral to treatment. So the physicians did a pretty good job in that arm, but they didn't do a great job screening their patients. On the other hand, in the non-physician provider arm, the medical assistants did a pretty good job screening the patients, but very few of the patients determined to be at risk ever received a brief intervention. And there were a lot of issues, a lot of barriers, problems with the warm handoff from the physician to the non-physician provider. People didn't want to stay and talk to someone. People didn't want to have to make an appointment if that was the model in that clinic. But for a lot of reasons, they never received a brief intervention. Both, though, you can see, did better than the control arm. So what we adopted for our regional implementation was we had medical assistants do the screening. We had physicians deliver brief intervention or referral to treatment for people who were identified as at risk. And this was really consistent with the screening workflow in Kaiser primary care already with smoking or things like that. And we were able to take advantage of a redesign of the medical assistant rooming tool. So the thing that the MA gets when, you know, they're weighing you and asking you if you smoke, they have a screen in the EHR, and we were able to get the alcohol screening questions right up there next to smoking and your weight and your blood pressure and so forth. So it was very timely. So you can see this is where we are as of, I think, November. We set, the medical leaders in the system set very high targets for screening and brief intervention. So they want to see 90% of patients screened and 80% of those at risk provided with a brief intervention, which are pretty aggressive targets. Right now, we haven't quite reached those, but we're very close, and I think the performance is higher than in most places except for the VA. So we're at 87%, and I can tell you that this is actually higher than the tobacco screening rates and higher than exercise as a vital sign and some other things that you would think might be easier and less stigmatized to ask people about. And we're at 65% brief intervention rates. Sure. It probably wasn't asked. So because there's an option, you can say refused or don't know the medical assistant, so they just didn't ask it for whatever reason. So they skipped through it, you know. They're not forced to, you know, it doesn't make them do it. You know, they can, I think, yeah. So here are our numbers through October. We have screened over 3 million unique patients since the implementation started in June of 2013 with almost, and actually I think it's now 5.5 million screenings conducted and over 300,000 brief interventions delivered. So it's you know, we're quite pleased with the numbers. Since you can see, and not surprisingly, we had quite low rates of brief intervention when we first started, and through our efforts, which I'm going to be talking about, you know, they've gradually increased to where they are today, and we hope to hit that 80% mark at some point. So, but it's just, it really requires a constant effort to, you know, educational efforts, booster sessions, little tweaks of the workflow, and so forth. This is what I was talking about. Right now, we're alcohol is a vital sign screening is higher than other required screenings. So this is the framework that we have really developed and the factors that we think have been critical in this implementation. So one is leadership support, and I hope that I'm going to be able to play a nice little video showing that. But it's been really important, particularly in a big health system like this, to have executive leadership give their imprimatur and say, you know, this is important to us. They're not telling anyone you have to do this, but they're saying this is an important priority for us, and tying it to the health of our members. This has been, from the very beginning, a multidisciplinary effort. So we have research staff, obviously, but also primary care, and they've really been the leaders on this. They're the people who are in the trenches and can say, that is never going to work here, or we really need to do such and such to help our MAs, you know, screen better, or to help our physicians do a better job at the brief interventions. Chemical dependency and addiction medicine, because they are the people there to receive these patients, the ones who are severe enough to need specialty treatment. Regional mental health has been key as well. And we have biweekly calls just to talk about how it's going. And the implementation facilitator, this has been a really important role that I think is critical in any kind of large implementation effort like this, to not only coordinate the effort, but also to provide coaching to the physicians, to the medical assistants, to everyone involved in troubleshooting. The technical assistance, by phone, by email. In the beginning, we did a lot more in person. We went to medical assistant huddles in the every morning to tell them, you know, how to work through and to try and address their anxieties about the process. And we have assembled these alcohol is a vital sign teams at every facility across the region, and this is pairing up an alcohol education champion who's a primary care physician and a chemical dependency liaison who is someone in the local addiction medicine program. And these people work sort of in concert. They're the point person to help their colleagues troubleshoot anything around this alcohol screening effort. And then the electronic health record. And I'm not sure if, well, I know that we could not have been as successful if this, some of these tools were not embedded in the EHR. We had a very specific evidence-based training. It was based on the training that we used in that original implementation trial. It was used a lot of the work of Rich Sates and Dan Alford. I don't know if you know them, but they're from Boston University, and it included, we did a train the trainers model. It included role plays and scripts that they could use just to make everything as possible, as easy as possible. We've also made sure to train all new medical assistants who come on board, all new physicians with the Affordable Care Act. Kaiser has hired many new physicians, and there's been a lot of onboarding. So we've made sure that the training on this initiative is part of that process. Performance feedback. This is something that's been absolutely key in this process, and I'll show you some examples of that. But it's really trying to encourage some healthy competition between physicians, between facilities, and providing that and having access to that data on a really timely basis. We get it from our operational quality metrics people, and we push those out monthly. And then we've developed a number of communications and marketing tools that I'll show you, aimed at physicians, aimed at medical assistants, aimed at patients. So leadership support. Now, let's see if I can do this. Where is my, sorry. Let's actually see if it runs. No. Okay.
Hello, I'm Dr. Robert Pearl. I want to thank each of you for participating in the advised study.
This is our Executive Medical Director.
Our ability to detect the alcohol problems of our patients, especially before they become severe, is a very important aspect of keeping our members healthy. If we can help them address these problems at an early stage, it will make an enormous difference in the future, for them and for us. Many patients who come to primary care medicine have an alcohol problem and would benefit from early identification and intervention. But all of us are busy, and this could feel like just another task to complete. For this reason, finding the most expeditious ways to identify these at-risk patients is crucial. The NIH has recognized the importance of this process and granted the TPMG Division of Research $2.5 million to help define the most efficient and effective ways to do so. But it takes clinicians like you to make it possible for us to learn the best approaches for this problem. I thank you for your willingness to participate in this study. In today's training program, you will learn the most up-to-date information about the role of excessive alcohol use on overall health. As you know, long before the development of full-blown alcoholism, heavy drinking produces pathologic changes in almost every organ system, as well as contributing greatly to injury, accidents, and domestic violence. The interaction of alcohol with other drugs, both prescribed and non-prescribed, makes these risks even greater. Our members, however, often are unaware of the chances they are taking with their health, and without our intervention, they will suffer the consequences. We are a national leader in disease prevention, and this is another opportunity to demonstrate our commitment and our excellence. I hope you find today's presentation and your overall involvement in the study both informative and useful. And I thank you again for the contributions that you are making, not just for the members of Kaiser Permanente, but for patients across the entire country. Thank you very much.
So you can imagine that in a large organization like this, hearing that from your executive director can be very persuasive. So let's see. Okay. And, it's not, alcohol is not in the front of most primary care providers' minds, so it was really important to have that sort of support. So I mentioned the teams that we've created at every facility. These are, just some of the things that we've done to try and create and support these teams. We've sent out matchmaking emails. Some of these people may not even know one another. These are big facilities, medical centers. So this introduces them, and we encourage them to get together for coffee and talk about the initiative. We meet quarterly with these people and talk about what's working and what's not, and we try and address those and tweak the initiative as we go along. A few screenshots. So this is what the medical assistant sees. So there's a little reminder there to please complete the alcohol screening for this patient. These are this is the actual instrument, and this is using NIAAA's single item binge drinking questions, and then we also ask about drinking frequency, the number of drinks that you have on a typical drinking day, and it calculates this, calculates your weekly average, and this is all tailored to a patient's age and gender. Then for the physician, this best practice alert will pop up, and this will say, okay, this person said that they had 4+ drinks in the past 7 times in the past 3 months, and they exceed the low-risk limits. They typically have 20 drinks, so it's populated with the patient's information, and then it offers some suggestions. So they've screened positive, provide brief advice to cut back and how to code it, and then it suggests some dependence risk screening questions to sort of further assess whether the person might actually be at risk for an alcohol use disorder, and it gives the physician these questions. You can see this is in a workflow, in a sheet, a flow sheet, sorry, so that the person's responses are tracked over time, and the physician can see, just like if they can see with their blood pressure or their weight, how someone is doing over time. I mentioned that performance feedback has been a really big part of this process. So some of the ways that we provide feedback, so we send every month screening performance by facility, and it's sent to the head of the facility. It's also sent to executive leadership so that the facility chiefs know that the executive leaders are seeing how they're doing on these. And it's sent to the managers of the medical assistants each month. And, so they can say, why are we at, 69% and not, why are we not at the 90% goal? We've also gotten alcohol screening onto the medical assistant report card, which the medical assistant manager reviews with the medical assistant when they have their, regular check-ins. So it'll show on an individual level how that MA is doing in terms of screening. We also, these monthly reports on brief interventions are also sent to the medical center chiefs and to executive leadership to see how they're doing, by facility. And then finally, we send individual provider level performance. So this is sent to your chief, your medical chief, every month, and it shows, within your clinic, how are you doing compared to your colleagues. And this has been really interesting. Some of the chiefs use this. They just go privately to physicians to say, hey, how come you're at, 0% on brief interventions with your patients? What's going on? How can I help support this? But some of the chiefs have just, chosen to use this in an unblinded way at staff meetings and really sort of try and spur that competition, and they've found that to be very effective. So. This is, you probably can't see this. So this is just an example of, one of the chiefs or one of the alcohol champions, and it says, I wanted you to see how great we're doing in our facility. This just shows, happens to be San Francisco, what a great job we're doing, and keep up the good work and so forth. So. So I'm going to show you another little video clip, and this was part of our marketing effort. And this was a video that was recorded by the chair of the adult medicine chiefs at the time that we started this initiative. She was a big supporter of alcohol screening, and I think what it really does is sort of hit on the challenges that they face as primary care providers in an environment where they have very little time, 15, 16 minutes for every visit, but how to, insert alcohol screening feasibly into those visits. So, and I think...
Yeah, I mean, alcohol affects a lot of medical conditions, from their high blood pressure to their diabetes, their obesity, their sleep apnea, their acid reflux. And so it's an important thing to find out, especially when you've got patients with those conditions. And so asking a screening question, and if it's above what the safe drinking limits are that, I've got posted there on the bulletin board in my exam room, it's a conversation starter, not just that it's not good for their overall health, but that it's specifically impacting, one or several of their medical conditions. And asking patients to cut down when their physician is doing that and they can see the impact on these other conditions they've got is typically helpful. And I've had patients that I think have been very successful a lot in losing weight when they just reduce from the 3 or 4 drinks a day they were having maybe down to 1 drink a day. And they didn't realize the impact it was having, on their other health conditions. And so that's been, I think it's a very useful thing to do, as well as just as a screening question, even for your patients who are healthy. If we're trying to prevent them from developing problems, we want to identify if they're really having more than is a healthy amount of alcohol in any given week. It's true. When we see a patient in clinic, the patient is coming in with their agenda, and they've usually, often got a list or got some things on their mind that they want me to check and take care of, or referrals, or, something. And then the physician, I've got my own agenda, which is, is their blood pressure under control? Is their diabetes? Have they had all their screening tests? And so I've got my agenda, they've got their agenda, and often, alcohol issues or alcohol screening isn't anywhere on either of those agendas. But, at some point, if this is my primary care patient, over the long term, it's really in my best interest to identify, and the patient's best interest as well, to identify if there's an issue with alcohol. And just, the vast majority of patients you ask, probably 93% of them, the number is going to be fully within safe limits. It took me 15 seconds to ask the question or less, and I can move on. And for those that it's not within safe limits, it's a big red flag, because that's going to be affecting a whole bunch of those other conditions. Because, blood pressure quality goal, if people are drinking more than about a drink a day, their blood pressure is going to be higher. Their blood sugar control, if they're drinking, much at all, it's not going to be having a good effect on their hemoglobin A1C. And so, increased risk for breast and colon cancer, certainly related to alcohol consumption, we know. So it's worth asking the question, because it does impact all those other quality goals.
Hearing from us at the Division of Research that these are important things is, that's one thing, but hearing it from a fellow primary care physician is another thing entirely, and this has been very compelling to the physicians. Dr. Sun was also tapped by the CDC to be part of their rollout when they initiated their alcohol screening and brief intervention effort, which in January of 2014. So she was a great spokesperson for this effort. This is something else. This is what I showed you before, but this is very compelling to physicians who don't realize how important it is and how effective and cost-effective it can be. We're also starting to use findings on health outcomes that we are starting to see from our earlier implementation trial and from this effort. So these are findings on the effect of receiving a brief intervention on hypertensive patients, and in blood pressure. We see drops in blood pressure, out of control blood pressure. We see drops in and in blood pressure control among hypertensive patients who received a brief intervention from their primary care provider. And this is really resonating with physicians. We're just starting to look at health outcomes in the patients in the actual Alcohol's Vital Sign initiative, clinical initiative, but we're seeing reductions in systolic blood pressure, particularly for women and the younger male age group, in blood pressure control, and in glycemic control, so in A1C control in patients. So these are very promising findings, and obviously something that the primary care providers are very interested in, and health system leadership. So a few other things we've tried to, in terms of training, we've tried to provide really clear scripts that the physicians can use. That they're uncomfortable, they weren't trained on behavioral health issues, and they really wanted, what do I say? So we've given them some of these strips. I'm concerned that you're drinking more than the safe low-risk limits. This could affect your whatever it is, your presenting problem that you came in with, your sleep problem, your weight, your diabetes, and I really suggest that you cut back. Very straightforward. We have tried to confront some of their anxieties about talking to people about alcohol, a lot of the stigma and a lot of the sort of misinformation that physicians also continue to have about people who might be drinking over the limit. And, giving them, providing them with information about the really small number of people that they're actually going to have to do a brief intervention on, that risky drinkers use 50% more primary care visits. So by addressing this, hopefully you can reduce those primary care visits. That's something that we found in a study that one of those earlier screening studies that we conducted in Kaiser Permanente. We've also, here are some training materials that we've used with the medical assistant, so really trying to recognize their key role as the first person, the point person that the patient encounters when they, come in for their visit, and acknowledging their important role, addressing some of the concerns that they had in the beginning. I don't think there are as many now, but they were really worried, what if people get angry? What if they refuse to answer? So, I told you we did, some huddles. We did a lot of training with them and with their managers to try and address some of these things. So, and to make it, give them answers that made it clear that all patients, I'm not singling you out, all patients are being asked about this. It's part of our emphasis on health and wellness here in this health system, and letting them know that they didn't have to badger patients. If a patient really didn't want to answer, that was fine, and they could just refuse and move forward. We also, coach them on asking the questions in the right way. So it's, there's a lot of evidence showing that if you say, in the past 3 months, have you had 5 or more drinks? If you don't typically drink that much, you think, oh, no, I haven't. And it's much more effective to ask how many times. That sort of normalizes it and lets people say, oh, yeah, well, there was that once, because that confers risk for accidents and injuries, even if it's a very infrequent occurrence. We've also done some, this is another effort. This is up in most, if not all, exam rooms. So providing information on drink size, typical drink size, because people tend to underestimate how much they're drinking with the way that drinks are served these days, and so do providers. So this is, good for both patient and provider, and it provides the low-risk drinking limits. We have these in different languages, Chinese and Spanish and Vietnamese. We also have created a wiki, and this is available to providers and clinicians not only in Northern California but across the Kaiser system, and there are actually 8 Kaiser regions, and this is a repository for all sorts of training information and instruments and so forth for providers, for medical assistants. And we've also been able to get some alcohol self-assessment tools into our patient portal, which all Kaiser patients, and in fact all you don't have to be a Kaiser member to access these. And it's a way to do a little self-assessment. This is something that people can just do on their own. It's something that your provider could refer you to. So you answer your information, and then it gives you, based on your answers, increased risk. Here's some, things. It indicates that you're at risk, gives you the limits, and then directs you to other services. So this one happens to be increased risk, and it directs you to some other self-help things on the portal. If you had indicated, if your answers indicated that you were at high risk, it actually directs you to specialty care services, and this is all tailored to your location. So this would be directing me to my Northern California specialty care addiction treatment. Okay, so next steps. One of the things that we're very excited about is that based on the success of this initiative, alcohol SBIRT is now one of the 3 priority areas of the Kaiser Permanente's national mental health and wellness leadership efforts. So I'll show you in a second. We're rolling out across other regions, and it's important. This is alongside of depression screening and primary care and suicide reduction. This is being, as I said, being rolled out now, and our team has been consulting with the other regions, so it's now implemented in Kaiser Permanente, Colorado. It's being implemented in Southern California, in Hawaii, and in the Northwest region. We have been collaborating for some time with the CDC and with the National Association on Chronic Disease Directors on their efforts to promote and implement alcohol and screening and brief intervention in chronic disease management programs, and the CDC really wants to tie it in, particularly given our findings on glycemic control and hypertension, tied in with their Healthy Hearts initiative on blood pressure. One thing that we're doing that both Derek and Connie have been involved in as sort of a next step with alcohol as a vital sign is for those patients who are more severe and who maybe have been given a brief intervention that hasn't worked, they keep coming back, they're still struggling with staying within the limits, but they've been unwilling to initiate specialty care. A clinician-to-clinician video consultation. So this is in real time. I'm a primary care provider. I'm sitting here with this patient, and I say, hey, you know what? You've really been struggling, and we've talked about this before. I'd like you to talk to my colleague. And so, pressing a button, using video technology to get an addiction medicine specialist from the chemical dependency program to get there on video. And there's a 3-way conversation. And the addiction medicine person might use some motivational interviewing to try and get the patient more interested in coming down to specialty care, or might coach the primary care physician on how to prescribe anti-craving medications like naltrexone. So this is something that we're working on now. We have our first training. It's, there have been a lot of challenges around the technology and everything. But we have our first training with primary care providers on Friday, and we're very excited about this. We're doing this in the Oakland Medical Center. And we're doing sort of, the only other specialty that has done this so far has been dermatology. So there are sort of video dermatology, real-time consultations with primary care, and we're trying to be the second. So we also have a proposal that will be reviewed later this month, which will be looking at the relationship between receiving a brief intervention and some of those health outcomes that I showed you, along with others. So depression and antidepressant adherence, gastrointestinal problems, I'm trying to think, cost and utilization, I can't remember some of the other, glycemic control, hypertension, and so forth. We also are working on another proposal to study the implementation and sustainability of this initiative and really look at an issue that has kind of dogged the screening and brief intervention world, which is fidelity and quality of the brief interventions that are being delivered, and what does that look like. And then as Connie mentioned, we have a whole program of adolescent early intervention and prevention work, screening, SBIRT, brief interventions, these groups, which are groups for both adolescents and their parents that we've been running in primary care, because so many of the adolescents that are seen in pediatrics, really they do not want to go to specialty care, even psychiatry, but particularly substance abuse treatment. You know, that's very scary. It's very stigmatized for them. Their parents are nervous about them going because they're going to meet other, you know, not other, bad kids. My kid's not bad, but the bad kids who are doing bad things. And so trying to figure out ways to integrate more behavioral health offerings in pediatric primary care. And you know, we've had a lot of feedback from parents. They're very interested in that. They're very anxious. The study that we have now, the groups, the parent group provides a lot of information on adolescent brain development, why are they acting the way that they are, the dangers of, you know, substance use to the brain, and how they can really providing positive support for positive parenting and teen and parent communications, and it's been quite successful so far. So, back to our model and how it's all worked. So these are our, you know, this is how it's worked in the case of this program of research. We have the SBIRT literature and the early studies that we did in Kaiser and elsewhere. That really turned into the ADVISE implementation study, and where we looked at ways to deliver SBIRT. That turned into alcohol is a vital sign. All the way along, though, we are getting feedback from our stakeholders and using that feedback to tailor these approaches. And then that is hopefully will result in new studies that are funded to continue to look at this. So. And this is our amazing research team. We have a lot of research staff based at the Division of Research, a lot of research staff who are out in the field, and these amazing clinical partners that we have, and without whom we would not be able to do this kind of research, real-world research. So, okay, thank you.